All right, hello everyone. Welcome to the McMaster Health Forum. I'm James, and I want to thank you for joining us here today for our third webinars from our QE scholars for this term. We have one more after this. It'll be next week on Wednesday at 3 o'clock. So an agenda for today's webinars. I will provide you a quick little summary of the McMaster Health Forum. I will give you a quick little rundown of our current Queen Elizabeth Scholarship Program, a summary of our new Queen Elizabeth Scholarship Program, and then I'll introduce you to our two presenters, Chloe and Sabrina. Chloe went to Australia and Sabrina went to Malawi in the summer of 2018. So the McMaster Health Forum is a leading hub for improving health outcomes through collective problem solving. We aim to harness information, convene stakeholders, and prepare action-oriented leaders, and act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose of the program is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The version of the Queen Elizabeth Scholarship Program that's offered here at the McMaster Health Forum is called the Strengthening Health Systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. This program, from which our two scholars will be presenting today, is ending this year, but we have been awarded a new scholarship program. We are one of 20 Canadian institutions to be awarded a new Queen Elizabeth Scholarship Program. It will run from 2018 to the end of 2021. This new program is called the Queen Elizabeth Scholarship Program in Strengthening Health and Social Systems. There are it's mainly the same program with a few differences, so I'll just highlight those differences now. First of all, the location of the internships has changed. The old program, we could only send students to Commonwealth countries or involve students from Commonwealth countries. Now we can all expand that to include low and middle income countries. Because of this, our partners have changed. We have the same partners that we had in our previous program. We've added two new partners, one in Colombia and one in Lebanon. The focus of our internships have slightly changed. We have expanded beyond health systems and are now also including social systems. And because of this, the eligible McMaster programs have changed slightly. All of the same undergraduate and graduate programs are eligible. We have added now the Arts and Science undergraduate program as an eligible program. And the number of opportunities has changed. In our old program, we hosted or sent abroad 61 students. In this new program, we will only be sending or hosting 24 students, so cut by about a third. With that said, here is the scholars from our current, now ending Queen Elizabeth Scholarship Program. Our first cohort, which is on the screen now, primarily went away or visited us in 2016. Our second cohort, which was quite large, 22 students, primarily went away or visited us in 2017. And our third cohort, which is also quite large, 25 students, of which our presenters are part of this cohort. These students primarily went away or visited us in 2018. As we record this webinar here in the fall of 2018, we have 5 students currently abroad. Our next scholar presenter is Sabrina Lin. Sabrina is an undergraduate student in the Bachelor of Health Sciences program specializing in global health. She aspires to better understand how to effectively translate knowledge within the policymaking sphere to make for better informed policy decisions. During her internship, she hoped to develop her critical thinking and research skills while further expanding upon her knowledge of health system strengthening in a global context. Ladies and gentlemen, Sabrina.
Thank you so much, James, for the lovely introduction, and thank you, Chloe, for starting the session off. So now I'm going to go forward with my presentation on my QES internship experience, focusing on the evaluation of non-communicable disease burden, risk factors, and interventions for NCD prevention and control in Malawi. And before I get started, just like Chloe, I want to make sure to give a big thank you to these 4 institutions and organizations who really made this whole experience possible for me. So Dignitas International, which is the NGO I was working at, for hosting me, the QES Scholar Program, and McMaster University for administrating the scholarship, as well as really first and lastly, but also foremost, McMaster Health Forum for equipping me with the skills and knowledge to really make a tangible impact and be able to bring my skills over to Malawi. So Just a quick agenda for today. I'm going to start with a contextual overview of Malawi and the NGO where I worked, moving on to the specific project that I spent most of my time working on, the NCD-BRITE project, going more into my systematic review work, finally kind of finishing off with some adventures I had while I was in Malawi and the lessons I learned while I was there. So yeah, contextual overview. Just like Chloe, I'm going to start with a map. So coming from Hamilton to Malawi, that was definitely a very, very long trip. And a lot of people ask me, why Malawi of all places? And for me, I wanted this QES experience not only to develop my knowledge in health system strengthening, but also my cultural understanding of the world and I guess my place in this vast, vast world that we live in. So this experience really served to broaden that perspective. And in Malawi specifically, so this is a map of Malawi. The point over there labeled Dignitas, that's actually where I worked and spent the majority of my time. That was the city of Zomba. Some other contextual points around the country, you can see Lake Malawi up at the top right-hand corner there. So Lake Malawi actually takes up 1/3 of the entire country of Malawi, and it's one of the main sort of landmarks of the country as well as their source for economy. The capital of Malawi is Lilongwe, so just about 4 hours from where I lived, and the main city center is Blantyre, and that's around an hour and a half from where I live. So while Dignitas is actually the 4th largest city in Malawi, from kind of our understanding in a Canadian context, I would say it's roughly the size of a small town. And so for more access to like imported goods or more services, you tend to actually have to travel to Blantyre, so that's quite a distance away. So traveling kind of comprised of a lot of my experience there as well. So Dignitas International is the NGO where I worked. So taking a blurb from their website, Dignitas International is a medical and research organization dedicated to improving access to life-saving treatment and care for HIV, TB, and related diseases in resource-limited settings. So they do a lot of work over in Malawi as well as here in Canada in the northern indigenous populations. Some three key facts about the organization. So it was established mainly in 2004 in response to the AIDS epidemic that was raging in Malawi at the time. Some of the core of their work involves training healthcare workers to deliver HIV-related services at clinics across Malawi. So they kind of bridged the gap between the patients currently needing to receive care, past patients, and also healthcare workers across the country. And finally, it's recently shifted part of its focus to NCD, so that's non-communicable disease care and management in the country because rates of HIV are, we're happy to report that the rates are going down, and so it's kind of in a transitionary period at the moment. So the NCD-BRITE project is the project that I spent the majority of my time working on while I was in Malawi. So just to provide a brief context to this whole project, so I mentioned in the previous slide that they're shifting their focus to non-communicable disease work. And the reason for that is, as you can see in that graph on the right-hand side, as communicable diseases in developing regions are going down over time, you can see that the mortality rates of non-communicable diseases are actually on the rise. And so that's kind of the reason why they're shifting their focus over to this area. Specifically in sub-Saharan Africa, the burden of NCDs is projected to overtake that of infectious diseases like HIV by 2030. So anticipating this, they're kind of dedicating more resources towards that. And one of the main causes of this is because of urbanization, lifestyle risk factors, HIV, and malnutrition. So the NCD-BRITE project was kind of created to address this. And so it's funded by the HLBS, so Heart, Lung, Blood Institute, Blood Sleeping Disorders Institute at the National Institutes of Health. And it's comprised of a consortium of institutions involved in this research and trying to develop research competencies in this area. And in Malawi specifically, this is addressing heart, lung, blood, and sleeping disorders. So involved in this whole project, it's kind of led by Dignitas International where I worked, but it also involved Malawi Ministry of Health, the College of Medicine, the University of North Carolina, a variety of various NGOs, and actually interesting to note is the Northern Ontario School of Medicine is actually involved in this project as well, because they found that a lot of the findings that they discover in the work in Malawi and Sub-Saharan Africa can actually be applied in our own northern communities. So that's kind of a neat connection for Dignitas in Canada. So an overview of the activities of this NCD-BRITE project. It's supposed to take place over 4 years, so it has 4 main stages. The first one is skills development activities, and so that means equipping nurses, healthcare professionals, policymakers with the skills they need to adequately manage NCDs in Malawi. Stage 2 is a needs assessment with regards to research infrastructure in the country. Stage 3 is kind of similar, but with regards to disease burden. And stage 4 is kind of an amalgamation of the first 3 stages and the knowledge that they captured there, and using that to develop a national non-communicable diseases research agenda in Malawi to hopefully further this area of work in the future. And so the work that I was doing mainly was focused on stage 3, so understanding exactly what the disease burden is in Malawi at the moment and what kind of areas needs to be addressed. So that goes into my systematic review, which was on evaluating non-communicable disease burden, risk factors, and interventions for NCD prevention and control in Malawi. So just for those of you maybe in the room or watching online who aren't too familiar with systematic reviews, a systematic review is an appraisal and synthesis of primary research papers using a rigorous and clearly documented methodology in both the search strategy and selection of studies. And analyses of systematic reviews is part of a lot of the work that the Health Forum here does. So basically it's a high-level summary of current literature on a specific topic. So the systematic review process involves kind of 6 main stages. So you formulate a research question, you develop a comprehensive search criteria to capture all the current literature on that subject, you search the available research through databases and great literature databases. You move forward to screen the literature and assess the quality of the studies that you decide to include. Step 5, you kind of extract and manage the data that you find. And finally, in step 6, you write the review and publish the results so that hopefully future policymakers or researchers can, at a quick glance, understand the field that you were doing your research on so that they don't have to go to the trouble of reading all that themselves, because trust me, it takes a lot of time and to really distill that information and understand a field of work. Yeah, I guess the slide isn't showing up too properly over here, but I just wanted to outline specifically for my systematic review what my methods were. So the research question that we were looking at was what is the current state of non-communicable disease burden in Malawi, as well as what are the risk factors and interventions for its prevention and control in Malawi. So for our search criteria, I included here kind of a simplified version of the search terms that we used, but basically it was a combination of hypertension, high blood pressure, diabetes, as well as Malawi to make sure that we're staying within the scope of that country. For the literature search, we searched 4 different databases, so Medline, OMBAS, PubMed, and the WHO Global Health Libraries. Quick note here is that normally in order to ensure that you have a comprehensive search, you tend to want to look into gray literature as well, but because of the dearth of literature in Sub-Saharan Africa and Malawi in particular, I was advised that you don't really have to look into gray literature because there isn't that much there. But finally, after we compiled the research from that literature search, we did a quality assessment using an 11-item checklist for the quality assessment tool. So this is here is a PRISMA diagram of the literature that I ended up finding. So from the initial search, we got 237 articles, of which 112 were duplicates. And from there, we went through a thorough process of screening the title and abstract. And after that, the full text using an in-duplicate method. So 2 different reviewers were looking at those independently to make sure that the screening process was kind of more secure and more comprehensive. And finally, 25 articles were included in our final systematic review. And yeah, this is here just a detailed look at the quality assessment tool we used. I just wanted to note that this quality assessment tool, I don't think was too rigorous, but we chose it to better cater to the level of research that's currently available in the Malawian setting. A lot of the studies we found were low to moderate quality just because of the limited research capacity there at the moment, but this is kind of a note for future work to help develop this field. So in terms of results, we found that for diabetes, the prevalence from various studies ranged from 1.7% to 5.4%, and the risk factors for diabetes included old age, high BMI, tobacco smoking, high alcohol consumption, physical inactivity, obesity, low fruit and vegetable intake. So this very much mirrored a lot of studies that we have in high-income countries in the literature. And in terms of one of some of the main sort of barriers towards management in this area included drug insufficiency, poorly trained personnel, lack of management protocol. So overall, we found that the management of these conditions was quite poor and definitely a lot of areas to improve upon. And for hypertension, the risk factors and management were quite similar, but for the prevalence it was a bit higher, ranging from 13.6% to 32.9%. So in analyzing those findings, I'll go into the discussion. So overall, you can see that there was quite a high burden of hypertension and diabetes in Malawi, particularly in comparison to the the countries around Malawi, as well as the global average. Unfortunately, most cases of these diseases are underdiagnosed, untreated, and inadequately controlled. So the risk factors, like I said, they're quite similar to high-income countries, but it's important to note that there was quite a large degree of heterogeneity in the included studies. You can see that the range, of the prevalence was quite varied, and that just points to perhaps a lot of methodological variances between the different studies, including sample size, the populations that they investigated, and the screening tools that they used. But yeah, study setting, sample size, diagnoses, missing data, and the data source. And overall, there wasn't too much of a time trend in the prevalence of these diseases because there was a dearth of literature available, so you couldn't really see that. Conclusion, so I wanted to highlight some barriers to disease management and barriers to research, both which have contributed to some of the struggles they've had in managing NCDs in Malawi. So first and foremost was underfunding to treatment facilities, and from that you have poorly trained clinical staff, oftentimes a lot of supply shortages at clinics. The clinic staff themselves often face a high turnover, and there's often shortages there. For patients seeking care, there's poor access because they often have to walk hours or take public transport to these clinics, and so that leads to oftentimes poor follow-up. In the population in general, there's kind of a lack of understanding of the symptoms and disease management protocols, so that when they see things manifesting in their symptoms, they don't really know what it is or whether they need to go to the clinic to seek help. In terms of research, I kind of mentioned before, but limited sample sizes is really impeding the validity or reliability of the research studies at the moment. Overall, one of the main barriers is also the lack of standardized diagnostic tools. So for my search, I found that the cutoffs employed in the various studies were all across the board. So it's hard to elucidate a clear trend if everyone's defining hypertension or diabetes in a different way. And so overall, that leads to a lack of research to help understand this field. So in order to overcome these barriers in the future, it's good at the moment that Malawi has a national action plan for the prevention and management of NCDs, and they're currently working at the moment on a renewal of this action plan for 2019. They also are in the works of developing integrated models of care to address that accessibility issue. So they found that a lot of times people with NCDs, they also can currently have HIV. So instead of the standard protocol right now is for people with NCDs to, go to Clinic A, and then also they have to treat their HIV to Clinic B. Oftentimes there's lack of access that way because it's kind of too burdensome for them. So recently we've seen arising these joint clinics that merge these two methods of care so that it's more accessible to patients. And also implementation of electronic medical record system was something that was happening at one hospital in Blantyre. So that has been improving the way that the clinic has been able to manage patient data and give them adequate care. In terms of research barriers, well, this project as a whole was kind of a means of addressing that. So establishing this consortium of research institutions to develop more competencies in research, implementation, and translation expertise. And publication of the systematic review will hopefully allow future researchers to better address this work. But yeah, along with the systematic review, I was also working on various different side projects during my time in Malawi, and I just wanted to highlight one of them. So this was an interesting week that I had in the capital of Malawi. And this was a series of knowledge translation short courses or workshops that they held to train different healthcare professionals and researchers on developing their competencies in knowledge translation. So it was really neat for me to take part in this experience to help develop that curriculum and kind of, I guess, act as a step to develop their skills and allowing them to, make a difference in their own respective workplaces. And so it was really promising to see them becoming really engaged in this work. Yeah, and moving on to Malawian ventures. So a lot of time I spent outside of the office was exploring the country, and it's truly really beautiful country. So this photo here is actually a photo I took one morning just in my backyard. So this is the view that I woke up to every morning and could sit in my backyard, have a coffee, and just see the layers and layers of mountains going into the horizon. And it was honestly one of the most beautiful things you could ever wake up to ever see. So I'm very grateful for that. Over here on the left is a safari that I went on. In the middle is a photo of some baboons just on a random day walking to work. So basically every day walking to work there's more animal surprises. Baboons are almost a daily occurrence. There's chickens running around. It was awesome to just wake up to a different surprise every morning. And the third one was a road trip I took, and that's just a photo of a typical traditional dwelling of Malawian people. Over here, so I was fortunate enough to live at the foot of a mountain. So just 5 minutes from where I lived was a very scenic Zomba plateau. So I did a lot of hikes in that area on the weekends with various colleagues from work, and that's one of their dogs. During the course of my internship, I was also fortunate enough to fly to Johannesburg to visit some of our other QE scholars over there, visit their offices, and see what they were up to. So that's a bike tour in a neighborhood of Johannesburg called Soweto. And finally, the photo on the right, that's Lake Malawi. So it's one of the key tourist destinations in the country. And finally, this is a trip I took to hike Mount Mulanje. So that's the highest mountain in southern Africa. It took 3 days to summit, and not like Chloe, I didn't do any ultra running or any of that, but I did slowly walk and work my way to the top. And also really interesting to know over there on the left, so you have two people running in that photo. That's actually a porter's race that was going on as we were hiking. So as we were, gingerly stepping on the different stones, trying not to fall off the mountain, these people were like just running down the mountain like at very high speeds. I don't know how they were doing it, but it was an incredible experience just to look at their physical abilities and how that compared to my own. But yeah, the middle photo is on the day of the summit, so you can see kind of how treacherous that experience was. And finally, the summit on the photo furthest to the right. Definitely, I think the most I've challenged myself physically ever in my life, and the views were definitely worth it. And the bonds I was able to develop with the friends that I went with, who are actually other interns from Ottawa, who were doing development work in Malawi. So some lessons learned to conclude my presentation. First of all, so from my research work in particular, it kind of reinforced my prior understanding of the importance of systematic research. So sometimes when you're doing systematic reviews, it might seem kind of cumbersome and just, you're summarizing work that other researchers have done in the past. But putting it in context in the NCD-BRITE project, it really made me realize the importance of the work in informing policymakers, and just the amount of time I spent trying to understand the literature and trying to make it understandable, I realized the work I was doing was truly a very, very key step in progressing the field of research. Number 2 was optimism for progress with regards to the global health field in Malawi, but also a cognizance of the amount of work still to be done. So like I mentioned before, Dignitas International is shifting a little bit away from HIV work, and that is optimistic because it demonstrates that rates of HIV are going down. So from, I think, when the organization was established in 2004, the rates of HIV in the country were around, I want to say 73%, but I'll check that later. But to this day, it's now like 7%. So you can see that a significant amount of work has been done. And so further change is possible, but also understanding that there is a huge step forward. Number 3, I was fortunate enough to get to become close friends with the country director and the deputy country director at Dignitas International, because the place where we lived, it was quite a small town. So basically every weekend you're spending together at barbecue parties, hiking, going to the beach. So I spent a lot of time talking to them about their work and understanding the politics associated with global health. So the collaboration between funders, NGOs, and governments, and how those various stakeholders work together to try to do the work that they do in these developing nations. And fourth, I think this was honestly my biggest takeaway of all, and it's the resilience of human spirit. So I guess a lot of times if you think about developing nations like Malawi, you think of how deprived they are maybe, like how unfortunate they are to be experiencing poverty, and the lack of a lot of things that we take for granted over here in Canada. But the people in Malawi that I met were honestly some of the happiest people, the most friendly, just satisfied people I've ever met. And every day in the office or at home, my housekeeper would say to me, we are so lucky to live in Malawi. Malawi is such a beautiful country. And that just kind of served as a very important reminder for me to be cognizant of what we have and also be grateful always. So yeah. And overall, I think this experience just served to reinforce or develop my understanding of my place in the world and potentially what kind of role I can play in the global health field or just the world as a whole. So yeah, Zikomo, that's Chichewa, that's language they speak in Malawi, and that means thank you.